Good morning. Hello, good morning. Welcome to this session, which is very packed, very crowded. It's very exciting. I am Javier Osorio from Barcelona, here in Spain. Dr. Berens, thank you. Dr. Berens from the Netherlands is presenting with me. We are having 10 videos today from surgical technique. So it will be 7 minutes for the presentation, and then we will have time for 1 or 2 questions after that, okay? So the questions will be in the middle of the corridor there. So after the presentations, you will be able to go there and present, to ask your questions. So we will be starting right now. The first video is from Spain, Cecilia Vila Riera, who will be presenting pathological progression after gastric bypass from chronic ulcer to gastrogastric fistula.
Okay, good morning. Thank you to the jury for the opportunity to present this video.
Gastrogastric fistula is defined as abnormal
please lower the
communication
volume,
between
please?
the gastric pouch and the remnant stomach after urinary gastric.
Okay, and restart again.
Although uncommon, it represents a clinically significant complication.
So gastrogastric fistula is defined as an abnormal communication between the gastric pouch and the gastric remnant after a one-wide gastric bypass. Although uncommon, it may compromise clinical outcomes such as weight loss and quality of life, and also it can cause persistent symptoms such as abdominal pain, nausea, or gastroesophageal reflux. Among etiologies, it may be secondary to marginal ulcer. Chronic inflammation at the gastric wall can progressively erode the gastric, leading to fistula formation between the pouch and the gastric remnant. We present a case of a 62-year-old woman who underwent in 2016 a laparoscopic one-eye gastric bypass. She was diagnosed after being discharged from routine follow-up with a marginal ulcer. This ulcer over time became chronic and was associated to persistent symptoms despite optimized medical treatment. Her current BMI was 23. So an upper endoscopy showed the marginal ulcer and then a small orifice in the proximal part of the pouch. Then the gastrogastric fistula was confirmed by a CT scan with oral contrast and with an upper GI contrast study as shown in the image. Due to the persistence of the symptoms and the failure of medical treatment, revisional surgery was indicated. We chose a robotic approach. Trocars were placed as shown in this image. We used 2 12mm ports and 2 8mm ports. First, the main anatomical structures were identified, the gastric pouch shown in blue, the alimentary limb in green, and the gastric remnant in purple. The first step was to release adhesions, first the ones between the gastric pouch, the peplon, and the gastric remnant with the vessel sealer, in order to identify the gastrogastric fistula. Then adhesions between the alimentary limb and the gastric remnant. This step was more technically demanding to the dense fibrosis secondary to the chronic inflammation at this site. And once the gastric pouch was fully mobilized and all the adhesions released, we passed around it an umbilical tape. And then we passed another umbilical tape beneath the alimentary limb so we could have controlled traction. Now you will see that the fistula is clearly identified, just adjacent to the gastrojejunal anastomosis. We transacted the gastric pouch proximal to the fistula with 2 blue stapler loads. Then the alimentary limb was divided with a white stapler load, and finally the fistula with part of the remnant was transacted with a green stapler load. We then reinforced the stapler line with a continuous bicryl suture. And of course, a new gastrojejunar anastomosis was constructed using a blue stapler load and the enterotomy closed with a continuous V-lock suture. And finally, the integrity of the anastomosis was confirmed with blue methylene insufflation, which showed no leakage at the anastomosis. The postoperative course of this patient was uneventful, and on the imaging follow-up, no recurrences were shown. So to conclude, gastrogastric fistula is a rare but clinically significant complication after a Roux-en-Y gastric bypass. Chronic marginal ulceration is a recognized risk factor for the development of gastrogastric fistula. Accurate diagnosis requires both a combination of endoscopic and radiologic assessment, and surgical revision is safe and effective treatment when symptoms are refractory to medical therapy. And definitive surgical management includes both complete fistula resection and construction of a new gastrojejunal anastomosis. Thank you very much.
Thank you very much, Dr. Vila. Any question in the floor? Dr. Vila, do you have the impression that this pouch could be resized to avoid the upper, because it looked a little wide, maybe?
Yes, maybe. White pouches, they are related to more marginal ulcers, so maybe it was in the case, yes.
Did you consider the possibility of resizing, or?
Not in this case, because this patient, she first was operated 10 years ago, and it was so chronic, so we thought that the best option was the resection of the fistula and constructed a new gastrojejunostomy.
Do you think that the timing of the surgery, so far away from the surgery, could help to have such a little local inflammation, which was very fibrotic but not very inflammatory, maybe?
Maybe.
So it's Thank you very much, Dr. Vila.
You're welcome.
Thank you.
We move on with the next video presentation from our colleague Dr. La Peña Rodriguez on the role of intraoperative endoscopy and management of complicated eroded gastric bands. Dr. Rodriguez.
Hello, everybody. I'm going to talk about
This is the case of a 50-year-old female with a history of adjustable gastric band.
This is a 50-year-old girl with a 26 BMI that a gastric band was placed 20 years ago, and she was referred to our hospital because of epigastric pain. Preparative tests show that you can see an eroded gastric band that was most likely completely intruded into the gastric lumen. So with that findings, we asked to the gastroenterologist to remove the gastric band with the lithotriptor, but due to that, the intense fibrosis, they were not able to remove at the endoscopy. So the patient was inpatient, but the 5 days after the endoscopy, she started with acute abdominal pain. A CT scan was performed that showed a lot of liquid in the abdomen, so we decided to go to the emergency room theater. Due to the gastric band, there was an intense fibrosis. We start with the dissection of them. We see here the stitches, so we thought the gastric band was placed there. We start the dissection, but we realized that where we thought the gastric band was, it was the tissue was soft, so we decided to perform an intraoperative endoscopy in order to know the exact place of the gastric band, avoiding unnecessary maneuvers, also because we were so close to the crura and in order to avoid complication. Here we see the abdominal, the gastric cavity, and at that level we do the retroflexion. And during the retroflexion we can see here where the gastric lap band was. We can see that it was almost completely fluid. And with that control, we can show by transillumination to the surgeon who is operating where is the exact place where the gastric band is. You can see how the surgeon tracked where we thought it was and how it was moving. So we know that we can continue the dissection on that place. Here we see the tube. And with that tube, we are going to track in order to make easy the dissection. You can see there's an intense fibrosis that we are coagulating it. Here we can appreciate that the gastric lumen and the mucosa of the gastric wall, we are seeing it. It was almost all the lap band intruded inside the gastric band, and we thought that because of that and the intense fibrosis was the impossibility of retiring that by endoscopy. We removed the gastric band and we set it to the microbiology department. And here we can see that we have a defect. We close it with a running suture. Due to that, it was like an intense fibrosis tissue. We decided to do a second layer one. And what happens when you have the intraoperative endoscopy is that you can use that in order to ensure that you have correct close that defect and see that you don't have overclose and you don't have any problem after retire the eroded gastric band. The postoperative outcome was fine. The patient was discharged on day 3 with antimicrobial and fungical treatment, and during follow-up she had a favorable clinical evolution. So we can conclude that endoscopy is an essential tool. It increases intraoperative safety, is crucial in complex surgery, and it allows us to closure and leak test confirmation. Thank you very much, and I hope.
Thank you. Is there any question from the floor? Yeah, could you use the microphone? Maybe hers? Maybe. Oh, okay. That's.
Hi. Thank you for the nice presentation. Did you consider the option of endoscopic removal of the band?
We tried it. We tried endoscopy removal, but it was impossible. During surgery. No, during surgery we didn't try because we also, I mean, it was the intense fibrosis, and it will, if we have tried, I think the result would be the same.
Do you think there is any criteria to decide whether there is a eroded band suitable for endoscopic removal or surgical removal is a better option to start with?
Always that it's intrude, like more than 50%. We try the endoscopical removal, and most of the time it was successful. But
does that depend on the buccal of the band, the site of the buccal?
Yeah, it depends on how intruded it is. So, and sometimes if it's just a little bit intruded, we wait, and if the patient is asymptomatic, we wait like 2 months and we try again the endoscopic removal, because we think it's better for the patient that go to the theater. But in this case, it was impossible, the endoscopic removal.
Yeah, thank you.
Thank you. This may be me, but I failed to see what the endoscopy added in this case to the procedure. It was beautiful surgery, but what did the endoscopic view do extra for you?
No, the scope, we have really bad experience with gastric band removals with severe complication, so we avoid to go to the crura and to go do an extensive dissection.
But you just follow the tubing.
Yeah, but after
So
we
you
have
don't need the endoscopy that much.
and after that, we are going to open that in order to do the leak test, and we have that, so it helps to us in order, so, I don't know, like it was a beautiful endoscopy, and we thought that it was...
It looked amazing.
In order
Thank
to
you.
say it.
Thank you
It
very
helped us,
very much.
I think.
Thank you very much, Doctor. So the next presentation is laparoscopic reversal of Roux-en-Y gastric bypass through jejunal interposition and partial gastric resection from Daniela Vázquez Acedo from Spain also. This is the Branco bypass.
Good morning. So we'll present a video of a laparoscopic reversal of a gastric bypass through jejunal interposition and partial gastric resection. Our patient was a 40-year-old female. She was a former smoker with the only condition of extreme obesity. She was intervened in 2008 by a gastric bypass with a preoperative weight of 160 kilograms and a BMI of 55. She achieved optimal weight loss, but she was referred to us by the endocrinologist because of 4 years of refractory late dumping syndrome, including postprandial dizziness, cognitive clouding, palpitation, sweating, and fasting hypoglycemia. We attempted previous treatments with acarbose, octreotide, somatostatin, dietary modifications, including a TOR, a trans-outlet reduction, without any success. So here the challenge of the surgery really is that there's no standardized surgical technique for a laparoscopic bypass reversal. Also, there's a high technical complexity and morbidity of a new resection and anastomosis in a reduced gastric pouch after the bypass, and that the patients tend to regain weight after the reversal. So our proposition is the jejunal interposition and intend a partial gastric resection. This was our port placement. And we started by identifying the previous surgical anatomy. We start removing some adhesions from the liver and from the omentum of the alimentary limb. We start also trying to find the remnant, the gastric that was secluded. Here we can see the gastrointestinal anastomosis and the secluded stomach. And we start measuring downwards 150 centimeters of the alimentary limb. Here we can see the jejunal anastomosis from the previous bypass, and we start following the biliary limb that we find out that it was herniated through the Peterson's defect, and we measured 35 centimeters of the biliary limb. Once we get the anatomy right, we do our first transection that is in the biliary limb distally. You can see a diagram of the anatomy of the surgery. We perform this transection with a linear stapler of a 10 load, protected, and we go back upwards to the alimentary limb. We performed this transection 10 centimeters away from the original gastrointestinal anastomosis, as you can see here. And we proceed to perform the new gastrointestinal anastomosis that will reestablish the anatomy. Here we'll start the gastric resection. We can liberate the previous adhesions of the stomach, and we perform a resection through the antral body junction. Here we'll do the gastrointestinal anastomosis, also with a purple load. We only use 5 centimeters to prevent wide anastomosis. We make sure the lumen is permeable, and we now close the defect with an absorbable barbed suture of the 3-0. We perform a transfixing stitch to prevent the kinking of this anastomosis. And we go back downwards to where we had the biliary limb. We'll do anastomosis to then get again the correct transit, we reduce the herniated biliary limb and perform an anti-peristaltic fashion anastomosis, you know. Also with a stapler, with a tan load. We close again the defect with an absorbable barbed suture. And we now correct the Peterson's defect to prevent any further complications. This we did with a non-absorbable barbed suture. We perform a leak test to ensure the correct anastomosis, and we take out the specimen with the bag. Now we insert a 19 French aspirated tube that goes through both anastomosis. We ensure hemostasis and complete our procedure. The patient, we had the reconstructive goals achieved. We made the whole procedure laparoscopically without any intra or postoperative complication, created a new restrictive unit, and corrected the anatomic defects. The patient started liquid diet the next day with a clinical improvement and resolution of the postprandial hypoglycemia, and was discharged on day 13, tolerating oral intake in combination with a supplemental enteral nutrition until she had the optimal intake. And we can conclude here that the technique is innovative. It reduces technical complexity by preserving the gastrorenal anastomosis and gastric pouch and reintroducing restriction through a tailored gastric resection. While this remains as a last option for refractory hypoglycemia and malnutrition, careful multidisciplinary assessment in expert settings is essential to achieve optimal outcomes. And here we'll have the diagram of the surgery. Thank you. No se ve.
Thank you very much, Dr. Vázquez. Any question from the floor? Dr. Vázquez, oh, sorry. Any question? Yes, of course.
Hello, thank you for your nice presentation. It shows also your surgical skills, so congratulations for that. In terms of challenges in surgical technique, perfect technique, but I have some questions about the rationale about it. First of all, why do you do resection of your remnant stomach?
Because of the regain of weight afterwards. Once we do a reversal, they tend to gain weight, so we try to prolongate the effects of the bypass that afterwards was to help her with her extreme obesity to prevent her to regain any weight.
I understand, but if you also look at the literature, there is high leakage rates when you undo a bypass, especially with this complex construction. If you have a problem at your small bowel interpenates, or you have a leakage and you did the big part of your stomach away, and the patient develops reflux, you're like closing your options for the future. And if the patient weight gain, okay, you can do it. But if you don't know if the patient is going to weight gain, I would say just leave the stomach there and keep your options open in the future. Okay. And my next question is, you're doing two anastomoses and one resection place. Why don't you just do a gastrogastrostomy?
Because it's a higher risk anastomosis, because once you have a little gastric pouch on the superior alimentary limb, it's a higher risk anastomosis. So we tried to see if it was a lower, and she didn't present any leakage.
Thank you.
Any other question from the floor? You please go to the. While she arrives, do you know, Dr. Vázquez, this technique was described by Dr. Ricardo Zorrón a long time ago. Are you aware of that? Which is called the Branco-Zorrón bypass, which is, we have done 3 for the same rationale, and we have had some ulcers in the anastomosis. Okay. Do you have a and Ricardo Zorrón, I don't know if he's here in the room, he also accepted that he had some ulcers with this reconstruction after that. Do you have a long follow-up of this patient?
She was intervened last year and she hasn't developed any ulcers from then.
Yes, please.
Good morning and congratulations for the presentation. I was actually asking the same question.
because of their own articles in the literature, and I just wanted to add another question. Do you experience any dilatation of the jejunal bridge?
No.
Okay. Have you performed any endoscopy after the surgery?
Not endoscopy, but barium swallow, and we see normal anatomy. I mean, normal, what you expect with it.
Okay, thank you very much.
Nothing.
Thank you, Dr. Vasquez. We continue with the next video presentation. I ask the technician to, as a default, turn off the sound. Dr. Fayez Molto, enlightening us on the bilious vomiting after Roux-en-Y gastric bypass. Dr. Fayez?
We present a 37-year-old woman with a BMI of 52, high blood pressure, dyslipidemia, and apnea syndrome, who underwent a robotic Roux-en-Y gastric bypass. Within the first 48 hours, she had severe epigastric pain and dyspnea, but the blood test and CT had no findings, so we decided surgical revisions due to the increasing of pain. And what we found was biopulmonary peritonitis involving upper abdominal cavity due to a leak that was in the anterior part of the gastrojejunal anastomosis. We decided to repair it with a simple suture, and after this the patient went well and was discharged on post-operative day 12. 48 hours later of discharge, the patient returned to the emergency room due to vomiting. And also blood test and CT had no findings, so we decided to admit the patient. During the hospitalization, she underwent an upper endoscopy, and what we found was that she has peptic esophagitis with severe bile reflux. After 10 days of recurrent vomiting and no findings on the test, we decided the second surgical revision. And what we first found were adhesions due to the previous peritonitis and also due to the leak. And after a long time of adhesiolysis, what we first found was the JJ anastomosis, and we started the bowel limb inspections from the JJ. After a long time of inspection from the JJ, we didn't have clear findings, so what we decided was to start the inspections from the ileocecal valve. So here we are inspecting the bowel, and this bowel should be the common channel. So what we found was that the common channel was ending at the biliopancreatic limb. That meant that the biliary limb was anastomosed to the gastric pouch and the alimentary limb was anastomosed to the biliary limb. Here we can see the BP limb anastomosed to the gastric pouch. And once we understood what it had happened, we started with the repair. So here we are going backwards the biliopancreatic limb until we arrive to the alimentary limb. And the first step is to transect the alimentary limb. Once the alimentary limb is free, it should ideally be anastomosed to the gastric pouch. But due to the previous peritonitis and the leak, we couldn't anastomose it to the gastric pouch, so we did another anastomosis near the gastric pouch, and of course in the correct orientation. So this is not a gastrojejunal anastomosis, but it's going to do the function of a gastrojejunal anastomosis. The next step is the transection of the BP limb. And after that, what we are going to do is to start the measurement of the new alimentary limb. This is going to be 1.5 meters. And after that, we will do the JJ anastomosis. This will be the final step of the surgery. And what we are going to do later is to rewatch the video of the first surgery. That, of course, we watched it previous the surgery, but we didn't know what was happening. So here is the video of the first surgery. We see the gastric pouch, the GG anastomosis at what we thought it was the biliopancreatic limb and the alimentary limb. They were rotated. So our mistake was that we transect the alimentary limb instead of the BP limb. And later, the second surgical revisions, the patient had no other complications, and after 6 months, she had a BMI of 39.4, no gastrointestinal symptoms, and this is the final transit. Thank you very much.
Thank you very much, Dr. Fayez. A very nice presentation. We have some disturbance from the next room. Sorry for that. Very nice presentation. Always commendable to face your own failures, and it's also commendable to show them to a broader audience, because I'm sure that many of us have similar problems once in a while. Also, a very creative solution. I think it's very wise to stay away from your gastroenterostomy that's still so young and only recently constructed. Any questions from the floor, maybe? None? Then I thank you, Dr. Fayez, for your very nice presentation.
Thank you.
So the next presentation is from the Netherlands, Dr. Mafalda Borges. She's presenting reversal of Roux-en-Y gastric bypass combined with Toupet fundoplication for the treatment of refractory dumping syndrome and GERD.
Good morning and welcome to this presentation on the surgical treatment. Sorry, this is not the same title as you said. Is it okay that I do this one first?
Oh, sorry. So
but I can do this one now and then the other one.
You have two.
Yes. But if it's okay for you, I just do
yes,
this
then,
one now.
Dr. Mafalda Borges will be presenting surgical treatment of refractory perforated marginal ulcer after OEGBP.
So welcome to this presentation on the treatment of refractory perforated marginal ulcer after one anastomosis. I have no disclosure. Our patient is a 55-year-old woman who underwent in 2013 an OEGB for a BMI of 51. And in terms of weight loss, she did very well. She reached a BMI of 26. But in 2021, she developed a marginal ulcer that was initially successfully treated with high doses PPI. Unfortunately, smoking cessation was unsuccessful. And in 2024, she came back with a recurrent marginal ulcer. You start again high doses PPI and you hope for God that it will get better. But she developed the ulcer perforation and underwent a laparoscopic closure of that perforation with omentoplasty. And some months later, we performed follow-up gastroscopy to see how everything was healing. And there was no healing of the marginal ulcer. So we suggested the resection of the whole complex of the OEGB and converted it to a Roux-en-Y gastric bypass. So we started by inspecting our anastomosis, and you see at the posterior sides a lesion at the small bowel, just distal to the gastroenterostomy. You see it there, it's retracted lesion that has been there for a long time, so there are some adhesions also. We started by taking down the efferent limb with a linear stapler. Then we took the meso down until we reached the afferent limb. We also took that one, resected that one with a linear staple, and we marked it with a clip so that we don't lose what is what. And then the pouch we also resected with a linear stapler, but here you have to watch out that at the back part you also have all your small bowel and you don't leave anything unvascularized behind. The previous biliary limb was 1.50 meters. We decided to shorten it to 70 centimeters, and then we performed a circular gastroenterostomy using the circular staple. And here you see how thick the tissue is, and you know already, oh, it will not be a good stapling, but at that moment it was the best to just fire and close the hole instead of taking it down and dealing with the perforation already at the small bowel. So we saw that it would not be a complete stapling due to the fibrotic tissue, but we decided to fire and close the opening with a barbed suture. Then we took down the candy cane and we did the transit reconstruction at the small bowel with a side-to-side linear stapler. And then we performed the second enteroenterostomy, creating a 50 centimeter alimentary limb. And the piece of small bowel that we used to insert our circular stapler was then removed. We closed the mesogaps also, and at the end we always do a leak test, showing a good open anastomosis and no leakage. Here you see the surgical specimen. At the upper part you see the stomach part, at the lower part is the small bowel, and then you see the inside of the mucosa. The mucosa was for a big piece gone, chronically inflamed, so you know it would never heal on its own, unless Dr. Zoron will say here that he will close it endoscopically. On the first day, we performed the upper GI series that showed no leakage. Patient was discharged 2 days after surgery, and at 8 months follow-up, the weight was stable, and she has complete resolution of the symptoms with good oral intake. So in conclusion, the treatment of refractory marginal ulcer after OHGB can be challenging, especially when patients keep on smoking. And when optimal medical therapy fails, also related complications can occur, and the resection of the OHGB anastomosis and conversion to a Roux-en-Y gastric bypass is a safe and effective treatment. Thank you so much.
Thank you very much, Dr. Borges. Any questions from the floor?
One question. Did she stop smoking after that operation?
No.
Roux-en-Y? Yeah, because she will definitely have another ulcer, because we have a lot of patients in Egypt, one anastomosis gastric bypass, and we see this kind of complication, ulcer, and then you do Roux-en-Y. In 2 years, they come back with the same ulcer. It's not about the pouch size.
No.
We thought in the past that Roux-en-Y will decrease the pouch size, then we will have no ulcers. But still, till now, we have the same ulcers after 2 or 3 years after Roux-en-Y gastric bypass.
Smoking is a big problem, and not all patients listen to us, unfortunately. I think everyone has those patients in this clinic. You have to keep on helping them, but you know they will come back with problems. That's a very hard thing to deal with.
Well, Dr. Borges, in addition to that question, some surgeons choose to do a total vasectomy to prevent recurrent ulcers. I personally find that a very scary step, but how's your view on that?
From the literature, I also don't see evidence that that's better, and you take risks. The biggest factor is the smoking, so you can do a vasectomy, but still they keep on smoking, so the mechanism is different. I don't think taking the risks of vasectomy will make it better or decrease the risk of the patient coming back.
Okay, thank you.
Dr. Borges,
was there another question in the back there? I saw a hand, I think. No.
Dr. Borges, your alimentary limb was 50 centimeters, I heard?
Yes. Weight was not an issue. But that's a plausible question. Why didn't you do it longer?
Because of biliary reflex, I'm thinking of.
50 centimeters should be enough to avoid biliary reflux. When you do a gastrectomy for cancer, 50 centimeters is also enough normally. But I understand your point.
Any other questions from the floor?
Since you're already up there, I suggest that we keep you there and then go to the next talk. Dr. Hussein, apologies for waiting a little bit. So we changed the program a little bit here. Is that okay with you?
For me, perfect.
Yeah.
If you're not bored yet of me.
So the next, your next talk then will be about the reversal of the Roux-en-Y gastric bypass combined with Toupet fundoplication of the treatment of refractory dumping syndrome and gastroesophageal reflux disease.
Yes, so this was also a challenging case, like the most cases we'd see at Dr. Dillman's practice. This was a patient who had, sorry, I will follow, no disclosure, a 57-year-old woman who had in 2070 an Roux-en-Y gastric bypass for a BMI of 35. Excellent weight loss, but severe dumping. And this time not late dumping, but early dumping. No hypoglycemia was documented. We tried all dietary modifications, all medication that you can think of. Nothing helped. Patient also came to us with reflux and diarrhea. Blood tests were normal, and the upper GI series showed hiatal hernia and some reflux. So we proposed to her to reverse the Roux-en-Y, but you know if you do that with someone that has already reflux, that the chance is there that she will develop even more reflux. So we suggested to combine an undo with keeping the fundus there and performing a Toupet fundoplication. So the most important part when you start undoing a bypass is perform good adhesiolysis, that you identify all the staple lines and that you know what are you connecting with what. Some surgeons would now choose for a vertical linear gastrogastrostomy. It looks anatomically acceptable, but functionally that's not the best option. In our center we see also a lot of revisional cases of undos in another center because they develop dysphagia, because when food passes through the gastrogastrostomy, it still has to go through that narrow piece there, and that gives functional problems. We know stomach is an amazing organ in terms of vascularization, but when it comes to motility, it has less good results. So the best option is to perform an horizontal gastrogastrostomy between the pouch and the previous horizontal staple line of your remnant stomach. So we started by taking down the small bowel with linear staple. Then we went to search the horizontal side part of your staple line in the remnant stomach. And here you see that we don't start at the corner. And why is that? Because if you have a mismatch, when you're closing it, you still have some marge to lengthen your opening at the remnant stomach, so don't start at the corner, start a little bit further. Then we resected a piece of that staple line, and you see a wide opening at the remnant stomach that we'll use to perform our anastomosis. Then we used a energy device to resect the pouch proximal to the previous gastroenterostomy. And when we undo it, we use hand-sewn anastomosis. So we use 2 barbed sutures. We start with the posterior wall, but at the corner, you start in front of the corner because that's also where the most leaks happen. So if you start anteriorly and then you go back, you know that corner is covered. And the posterior wall we do with full thickness bites, small steps, Be generous in your bites. It's stomach, so it can have it. And then in real time, it takes a little bit longer than this. The posterior wall is now closed, and then we use another barbed suture to close the anterior wall. And again, you see here very clearly where your corner was from the back part, and then you know you will not have a leak there. At the anterior wall, we do inverting the mucosa, so serosal stitches. That's done. We perform a leak test, as always, not only to see if there is a leakage, but also to interpret our patency of the anastomosis. And then we did reduction of the hiatal hernia, dissection of the hiatus, and then we used the fundus to perform our toupee fundoplication. We used on one side 2 stitches and on the other sides 2 other stitches. And here, indeed, you have to see that the tension is correct and that you use it. This is non-resorbable ethibond. And then we close the crura, of course, also with non-resolvable stitches. We bring in the gastric tube to see if the tension is good and if there is a good passage at the level of the hiatus. And you see you have a nice wrap around and a nice open anastomosis. We always leave our alimentary limb as a blind loop. A lot of people remove it, but again, these patients will maybe come back, so don't resect anything that it's not needed because you're closing, you're diminishing your options for the future. At day 1, we also performed upper GI series, and then you see here very nicely contrast going down your stomach and also in the wrap, and also the air in the wrap, which will guarantee a good anti-reflux mechanism and no leakage. Patient went home 4 days after surgery, and at 3 months follow-up, she had no dumping, no reflux, no diarrhea, good intake, and a stable weight, so a happy patient. In conclusion, in selected patients with severe therapy refractory dumping syndrome, gastric bypass reversal may be the only effective option to achieve complete symptom resolution. Horizontal gastrogastrostomy is still the best functional option, and concomitant toupee fundoplication is safe and effective for associated reflux. Thank you so much.
Thank you, Dr. Borges. Any questions from the floor? Go ahead. Maybe use a microphone, either hers or in the middle.
Thank you very much. Is there any, at least theoretical risk of bacterial overgrowth in the hanging alimentary limb that was left in the abdomen?
No, it's just a long blind loop where food doesn't pass, so we don't see any problems, no. But I understand your question.
You didn't see any problems after 3 months, maybe, but it is a valid question.
Yeah. Now,
why didn't you take it out after having done such extensive surgery?
It's not our first undo like this. So the follow-up from this patient was 3 months, but the follow-up from other patients that we undid, is that the word? It's longer and we don't see any problems. And for example, we had recently a case of a patient who had to have, for other reasons, after undo bypass, a total gastrectomy. And then you are happy if the alimentary limb is still there. Because bringing something up to the esophagus, if the alimentary limb is not there anymore, is a big challenge. At that patient, we had another long blind loop, but it was a drama case. But if you see bacterial overgrowth, you can still go back and excise it, but if there is no problem, just keep it there and keep your options open for the future. I think us as bariatric surgeons have to think we don't do only one procedure per patient, so keep your options open for the next one.
So, okay, but then would you be prepared if this patient, because you showed data after 3 months, she didn't regain any weight, but would you be prepared to go in after 2 years when she gains 30 kilograms?
Yes, you can still sleeve your stomach, and you have, I hope Professor Noka is here listening, you have a nice Nissen sleeve after undo. Why not? Just stay creative, yeah.
Okay.
Two-pad sleeve, yeah. I will publish it in the future.
You're a brave woman. Okay, thank you, Dr. Borges.
Thank you.
So the next video comes from the UK, Dr. Hossain, who's presenting a complementary to the other cases. So from Toronto, sorry. From Canada, sorry for that. It was complementary to the other case. It's an endoscopic removal of eroded gastric band with laparoscopic assist. It's the opposite of the Spanish case, isn't it?
Yeah, so we have it in Canada, and thankfully we were able to do it endoscopically. We can keep the sound on for this, please, and just restart from the beginning.
In this video, we present a case of endoscopic removal of an eroded gastric band with laparoscopic assist. We have no conflicts of interest or financial disclosures. This is a case of a 56-year-old female referred for chronic recurrent elevated C-reactive protein on blood work, along with an infected gastric band port site for several months. Her past medical history is significant for hereditary spastic paraparesis, for which she had 2 attempted intrathecal baclofen pump insertions, but both were complicated by infection requiring removal. Her gastric band was inserted in 2010 at an external site. The band unfortunately slipped 4 years later, requiring removal and reinsertion, also at an external site. Given the history of port site infection, we had strong clinical suspicion of eroded gastric band and thus proceeded with gastroscopy. Gastroscopy in this retroflex view revealed 80% gastric band erosion. Thus, we moved forward with the endoscopic gastric band removal with laparoscopic assist in the OR. We opted for laparoscopic assist to perform a provocative leak test, given the patient had previous band complication and reinsertion. This is our initial endoscopic view revealing the approximately 80% band erosion. Our plan was to use the Suhendra mechanical lithotripter device for endoscopic removal of the band. This device, as pictured here, is typically used for crushing biliary and ureteric stones. Here we demonstrate use of the Suhendra device. A guide wire is inserted around one side of the gastric band and retrieved through the inside of the gastric band to lasso around it. Both ends of the wire are then inserted into the Suhendra metal head, tubing, and the crank device. At this juncture, we took a look laparoscopically, which revealed a hostile upper abdomen. Here we can see the metal head of the lithotripter device going down over the 2 ends of the wire to lasso around the gastric band. It is crucial to endoscopically view the entirety of this metal head going from the mouth into the stomach to avoid injury to any interlying structures, including the tongue. Here we can see that the wire is lassoed around the gastric band and the crank device used to split the gastric band into 2. The band is then retrieved and the tubing and port are removed extracorporeally. Final view, endoscopically revealed no remaining gastric band. Additional laparoscopic ports were inserted with lice of adhesions to then perform a provocative leak test. The leak test was negative, as demonstrated here. Lastly, here we can see the fistula tract of the tubing portion of the gastric band going up into the falciform. Given that this was a long and narrow tract, we left this in situ. Postoperatively, the patient did well. After 2 days of being kept nil parosseus, their diet was advanced to clear fluids and eventually to regular solid food. There was no issues with any of this. The infected port site was managed with daily saline-soaked packing. She was then discharged home post-op day 7, and on follow-up visits at 5 and 8 weeks post-op, she has been doing well, and the infected port site wound is healing. In conclusion, all foreign bodies should be considered as potential sources of infection NYD cases. Secondly, patients with infected gastric band port sites should have investigation for band erosion. Lastly, the Suhindra lithotripter device may be used to endoscopically cut the intraluminal aspect of an eroded gastric band. Thank you.
Your question and my question?
Your question.
Thanks, Dr. Hussain, from your very nice presentation. In the former presentation, my question was, what was the added value of the endoscopy to your laparoscopic procedure? In your case, I would ask, what was the added value of your laparoscopy in your endoscopic?
Yeah, so we had planned to do both modalities because of the patient's previous complication with the gastric band requiring reinsertion. We didn't know if it would be a similar case to the previous one that was presented, that it would be endoscopically impossible to remove. And then we also wanted to make sure that there wasn't any tears in the capsule so that we could repair it at the same time. If that fistula tract was really wide and short, we would have managed that as well, and to do our leak test as well.
I can appreciate the safety measures, but do you think that's always necessary to check laparoscopically?
No, definitely not. For most of them, we do not do it. For this one, we did because of the previous reinsertion of the band, but for 99% of them that are endoscopically removed, we don't do any laparoscopic assist.
Okay, thank you. Any questions?
Microphone, please.
Sorry. It's just a comment. What would you do with the tubing system if you don't need a laparoscopy? So, yeah, the tubing system, I think in this case, it was removed in advance, a couple of years before. The tubing system from the port to that. I think the laparoscopy is essential to extract the tube, the port and the tubing system, and then you can take the stomach out from the inside.
I disagree. It's not. You just take out the port and there you see the tube.
Does it come out?
Yes.
Always.
Okay, yes.
We did that for this case too, so like you said, you don't need the laparoscopic part for that. You just cut over top of the port, and then there's usually some infection, and then you pull the whole thing out. It comes out very easily for the most part.
So thank you, Dr. Hussain. We move on to the next presentation, which is done by... Thank you. Which is done by our colleague from the UK, Josephine Mollier. I probably pronounced this in French. Yeah, Mollier. And she's going to educate us about lost in loops, navigating the mesenteric maze of internal hernias post-gastric bypass. Dr. Mollier.
Good afternoon. I'm delighted to present 3 cases of internal hernia post-gastric bypass surgery. Is it playing? Is it playing? I don't know if it is.
It's either a very long introduction or...
It shouldn't be this long. There we go, and we have no declarations. So our first case is a 39-year-old man with a background of sleeve gastrectomy converted to Roux-en-Y in 2023. He presented with sudden onset upper abdominal pain 2 days prior, but was actually discharged home. He re-presented with persistent pain, had bloods that showed no significant abnormalities, but had a CT showing an internal hernia. So he subsequently underwent an emergency diagnostic laparoscopy. A bowel run was done starting at the terminal ileum, progressing proximally to the root limb, as you can see here. We found Roux-en-Y gastric bypass anatomy, and Peterson's and the jejunojejanostomy defects were widely open. An internal hernia through the jejunojejanostomy defect was identified with congested but viable small bowel. Therefore, both defects were closed in a purse-string fashion with ethibond sutures in a tension-free way with minimal mesenteric bleeding, as you can see here. Okay, and as you can see, his post-op outcome was very good. Went home on day 2. So our second case is a 51-year-old lady who had a history of Roux-en-Y and presented with sudden onset epigastric pain with associated nausea. She was opening her bowels, afebrile, but on examination she had a tender upper abdomen without any peritonism. Blood tests revealed no abnormalities again. However, CT did show signs of internal hernia, so swelling of the small bowel, mesenteric vessels. So she also underwent an emergency diagnostic laparoscopy. Again, a bowel run was done, starting at the terminal ileum and progressing proximally. So Peterson's and the jejunojejanostomy defects were again widely open.
Very typical.
As you can sort of see. So you can see the small bowel was reduced. And again, the defects were closed using ethibond sutures in a purse-string fashion. So you can just see that here. Okay. So post-operatively, her recovery was uneventful. Again, she went home the following day and was seen in clinic very well. Our third case was a post-op 1 anastomosis gastric bypass. She presented with vomiting and upper abdominal pain, but CT actually showed no features of internal hernia. However, her pain persisted, so we therefore decided to take her for diagnostic laparoscopy. Again, we started off with a bowel run from the terminal ileum, as you can see here. And we found an internal hernia 3 Peterson's defect, which was successfully reduced. The bowel was healthy, so no bowel resection was required. And you'll see here that, again, we closed the defect using a purse-string approach. And her post-operative outcome, again, was very uneventful. So in conclusion, internal hernias after gastric bypass surgery do require a high index of suspicion, particularly with atypical presentations. Due to the altered anatomy, we think that a stepwise approach is critical, so starting at the terminal ileum. And progressing proximally, safe reduction of the hernia contents, and then definitive closure of the mesenteric defects. Thank you for listening.
Thank you, Dr. Maillet, for a very nice presentation. Although your title was a little bit philosophical, lost in the loops, you didn't seem lost at all, in my opinion.
Yes, no, well, not in this case, as Mr. Faki Gomez was operating there. I think the main point of this was just to show a systematic approach for anyone to follow, basically, which is really useful for somebody like myself, a junior trainee, and also at centres where bariatrics isn't necessarily something that's sort of done very often there.
Yeah, well, I agree, but only in the third case you showed that you started at the terminal ileum, and the other two, you just went for it.
Both started at terminal ileum. I think the video didn't necessarily show the whole, we didn't have time to show the whole thing, but yeah.
I couldn't help noticing that you were using non-absorbable sutures on the small intestine itself. Many of us would be afraid to induce fistula there. How's your view on that?
So I think the rationale behind using the non-absorbable sutures is just that they're obviously more durable, reduce risk of loss of tensile strength over time.
They're definitely more durable, but that's exactly the problem on small intestine, right?
Yeah, absolutely. I mean, in the three cases that we had, there was no fistulas post-op. But yeah, absolutely understand your point.
Thank you. Any questions from the floor?
Thank you very much.
Thank you.
The next presentation, I hope, is from Spain. I hope they are also enthusiastic like this from the UK. So we're playing at home, so I hope you clap a lot. So the next presentation is laparoscopic revision of gastrojejunal anastomosis for refractory marginal ulcer guided by intraoperative endoscopy from Magdalena Monacid Martinez.
Good morning. Laparoscopic revision of gastrojejunal anastomosis for refractory marginal ulcer guided by intraoperative endoscopy. We present a 47-year-old female patient with obesity, BMI increased from 42 to 50 kilograms per square meter, and a history of smoking. Initially underwent a sleeve gastrectomy, but 6 months later, a conversion surgery to Roux-en-Y gastric bypass was performed due to a suboptimal clinical response by persistent reflux symptom and vomiting. After that, the patient persistent vomiting and dizziness. So we did an endoscopy. We diagnosed a marginal ulcer of the gastrojejunal anastomosis. We prescribed a medical treatment with omeprazole, sucralfate, and smoke cessation, but the marginal ulcer was classified refractory. We saw that in the second endoscopy, the marginal ulcer, it got worse. The bypass ruled out malignancy, and the upper GI series ruled out gastrogastric fistula. We decided to do a revision surgery. The patient was placed supine position, and we used 4 ports. In the abdominal cavity, we saw an inflammatory mask at the gastrojejunal anastomosis, and it was implicated the gastrojejunal anastomosis, the gastric remnant, and the left lobe of the liver. We initially do the dissection with scissors and bipolar energy. After that, we can see that there are the ulcer bed, the alimentary limb, the gastric remnant, and the gastric pouch. We did an intraoperative endoscopy that we can see the ulcer bed, and we confirm the gastrogastric fistula. First, we have the resection of the gastric remnant with a blue linear stapler. Then we did mobilize the alimentary limb, and we section with a white linear stapler. And finally, we did the intraoperative endoscopy to resect, to ensure the inflammatory mask. now is the intraoperative endoscopy. And then we did the resection of the gastric pouch with a green staple linear. Then we did the new gastrojejunal anastomosis with a blue linear stapler. And we close the defect with a barbell suture guide to a nasogastric tube. After that, we did the methylene blue test, with, which was no leaks. And Jackson Pratt ring was placed in the gastrojejunal anastomosis. The patient had a favorable postoperative course with no early complication, and to nowadays the patient remains asymptomatic. But she continues smoking. We conclude surgical revision of the gastrojejunal anastomosis is the definite treatment for refractory marginal ulcers that fail medical therapy. The integration of intraoperative endoscopy is essential in complex revision surgery to guide resection and ensure healthy tissues for reconstruction. Identifying and resecting anatomical contributors optimize long-term success in patients with complex surgical histories. Thank you.
Thank you very much, Dr. Almonacid. Any question from the floor? Dr. Almonacid, I didn't see you closed the Petersen space, but I imagine it was closed. You checked that already?
Yeah.
The Petersen space, you didn't show the closing of it, but I imagine it was closed already. You made sure it was closed. The Petersen space. El espacio de Petersen.
Sorry, I don't understand the question. It's closed, yes, yes.
So, yes. It was closed. Mm-hmm.
Yes.
So they confirmed that they revised both of the spaces and they were already closed.
Yes.
So perfect.
They both are closed, yes.
Perfect. Any other question from the floor? So this was more inflammatory than the other case because of the timing. Yeah, it was difficult. The dissection was more challenging, wasn't it? The inflammatory state of the local.
Yes, it was the inflammatory in the ulcer bed, and when the medical treatment was refractory, the marginal ulcer to the medical treatment, we decided to do a surgical revision.
Perfect. Any other question? So I think we are with the last presentation, isn't it?
Yes, I think so. Which is given by Dr. Therver on the lessons learned from complex fistula after sleeve gastrectomy. Dr. Therver.
Good morning.
Good morning.
We present the case of a 41-year-old patient who underwent a laparoscopic sleeve gastrectomy at another institution. After surgery, the patient developed recurrent pulmonary infections, progressing to emphysema, and a transdiaphragmatic fistula. Initial management was conservative, including fasting and a placement of a bariatric stent without resolution. A gastrointestinal test confirmed the fistula. Computed tomography showed a bronchopleural fistula with left-side emphysema. A perisplenic collection extending towards the gastric remnant, and a colonic suspicious involvement. Endoscopy showed a small fistulous tract, a small fistulous orifice less than 1 centimeter,
and a persistent fistula with purulent drainage after stent removal. Colonoscopy did not identify any obvious defect at colon. Due to lack of conservative treatment, surgical management was necessary. Intraoperative endoscopy confirmed the fistulous tract, and in surgical exploration, we show a gastric-dependent transdiaphragmatic fistulous tract. After retrogastric dissection and the mobilization of the left diaphragmatic crush, the fistula was manually divided and the fistulous tract was closed with non-absorbable sutures. All mesenteric defects was closed with non-absorbable sutures, as well as long port sites longer than 1 centimeter. A hand-seam gastrojejunostomy was performed with Rosenai reconstruction. We used to perform that a 3-technique layer. The first step was posterior seromuscular layer suture, later the enterotomy, now the posterior mucosal layer suture, and finally the anterior layer suture. We did the andocyanin green leak test that was negative. Initial postoperative recovery was uneventful. However, 1 month later, the patient developed persistent coat and full smiling sputum. The computed tomography with rectal contrast demonstrates passage of contrast from the colon into the respiratory tree. As well as contrast within the gastric remnant. That's the reason why there was necessary a second surgical management. We show an intact gastrojejunostomy and a colopleural fistula shown in the splenic flexure. A colonic resection with primary anastomosis was performed, and an omental flap was used to shield the pleural cavity, securing closer the communication with the lung. And in the end, beyond the surgical complexity, the success is defined by the outcomes and the patient satisfaction. Thank you very much.
Thank you, Dr. Sefer. A beautiful presentation, and I think many of us are familiar with these disastrous cases after sleeve gastrectomy. What do you think of the approach not to go into fistula treatment at first, but to convert early the high-pressure system that a sleeve is to a low-pressure system such as no AGB, for example, within the first week after primary surgery, and then leave the fistula as it is, because, as you know, after OAGB or Roux-en-Y gastric bypass, a leak on your vertical staple line isn't that not that bad?
Well, I think it's because the patient had correct a correct loss weight, and it didn't need a more ponderal weight. And
Yeah. Oh yes, please.
So I didn't understand, Shirley, your question. You're asking me why I didn't convert to a bypass, or
What no. That's I know. I did. I would probably have done the same thing as you did. Now, maybe 5 or 10 years ago. Nowadays, we in case of sleeve leakage, we convert early to a low pressure system, which is and probably an OAGB is the simplest.
at the moment we thought that the patient was not problem with the plastia, okay, because it was working correctly, and we thought that the problem was only the fistula. It's not because of a bad drainage of the plastia.
Yes.
So that's we thought it was better to go for the fistula and transect the fistula, because we thought that leaving the plastia was the best for this patient.
I understand.
Not a problem with the regain weight, not problem with the empty of the plastic.
I understand. Yeah.
I think it's more difficult to perform this surgery. I think it probably is easier to do a bypass. I don't know.
Yeah. Well, that's why I'm suggesting it. I agree. I would probably have done the same back in the past. Nowadays, we don't do the hassle with stents and failures and refistulas and stuff like that. Convert early to the low pressure system, and the fistula is not a problem anymore.
Yeah, but
Strange
it's
enough.
not a patient from our hospital.
Okay.
Patient because of we are centered.
I understand. That makes it extra complicated. Yeah.
Yeah.
And a question over there. Sorry.
I don't think the mic is working. Is it working?
Can the technician put the mic on, please? Switch it on. Can you try?
Do you hear me? Yeah.
Yeah.
I had one case that was very similar, almost identical to the people from Spain. It was a late fistula, 6 weeks after sleeve. I think the main problem was the migration of sleeve in the thorax. Then the fistula developed. It was maybe 2 millimeters in diameter. And at the first it was gastropleural fistula, then it was gastropleuробronchial fistula. And the main problem, and that is why I support the guys from Spain, you have the negative pressure inside the thorax, and it's always sucking the content from the stomach upwards. And my patient had recurrent pulmonal infections. First we tried conservatively, maybe 6 to 8 weeks. She was in hospital. She lost so many weight. Then we did total gastrectomy, and the patient was discharged. And afterwards, maybe 1 month later, he was coming back with recurrent pulmonal infection. Then we transferred the patient to thoracic surgeons, and they did the patient end up with left lower lobectomy.
Wow.
Now she's well, but I think it's very...
And you didn't have the communication with the colon, right? Like in this case.
No, there was no communication with the colon, but when you have the fistula, which is going up,
I know.
the negative pressure area,
Of course.
I don't think the conversion of sleeve to low pressure procedure would solve the problem.
Would have helped.
Maybe I'm wrong, but
okay.
I think so. Thanks.
I agree.
So this was the last presentation. Thank you very much. This was an... Thank you very much to the audience for this participation and for the timing of everybody. Thank you.